Okay, so this is going to be a very quick video, but this is going to cover abdominal pain, both acute and chronic, and inflammation with the GI. So this should go fairly quickly. Um, Anyways, all right, so let's start with acute abdominal pain. Acute abdominal pain, obviously, acute is a sudden onset of abdominal pain. And in acute abdominal pain, we're trying to figure out the cause. So that's going to be our primary thing, is figuring out what's causing this acute abdominal pain. So let's start off with, with the acute abdominal pain, obviously, it's going to be tenderness. Patients are going to have guarding. And other than that, it's fairly self-explanatory. So some of the causes, let's not go through the definitions, but some of the causes of the acute abdominal pain, you have anything in the itis. All right, so it's appendicitis, peritonitis, bowel obstruction, colitis, diverticulitis. So anything that's causing inflammation in your GI area, if it ends in the itis, all right, it can be related to acute abdominal pain. But let me write them down anyhow. All right, so you have appendicitis. Of course, I have to look at something because I can't spell. Appendicitis, pancreatitis. Again, all your ifs. Colitis, diverticulitis. Gastritis. Alright, I think you get the point there. If it ends in itis, if it's inflamed, if it's in your GI, it can cause acute abdominal pain. Alright, pelvic inflammatory disorder. You could also have ectopic pregnancy. Acute pancreatitis, already hit that. So these are some of your more common ones. Alright, so you have any of your itises, it's the itis. And then your pelvic inflammatory disorder, again, inflammation of the pelvis, a lot of times related to STDs. Anyhow, and then ectopic pregnancies. So those are some of your main causes of acute abdominal pain. Obviously, it's something that we need to figure out sooner rather than later. And with any of your GI issues, you're going to want to watch ionos, you're going to want to watch vitals, and you're going to want to watch your fluids, and 99.999% of the time keep somebody NPO. Alright, so that's just as general. I mean, that's kind of any GI, at least until you figure it out. Alright, so some of your symptoms associated with acute, as you might imagine, pain is going to be your most common because it is acute abdominal pain. Nausea, vomiting, diarrhea, fatigue, a fever related to infection, and bloating or distension of the abdominals. And those are just some of your symptoms. Your diagnostic studies, again, we're going to be looking at CBCs. We're going to be looking at our UAs. CBCs, we want to check our white blood cell count because, again, if our body's fighting infection, then it's going to have an elevated white blood cell count. So some of your diagnostics studies here, obviously you're going to want to do a physical. You're going to look for abdominal bloating, abdominal distension, rigid board-like abdominal. You're going to look, listen for bowel sounds. Obviously, bowel sounds are going to be important in any of your GI issues. Again, monitoring that vital signs, and a lot of that has to do with the risk of hypovolemic shock and sepsis, which is you can have septic shock, of course. So you have hypovolemic shock or septic shock, as were the two main complications that you're looking for. So anyways, physical, you're looking for bruising, distension, anything out of the abnormal, abdominal sounds, pain, rebound, tenderness, where you push in, and then when you let go, it hurts. We're also going to do our the complete blood work. That's a huge weird. All right, UA, you want to see what's going on there. X-rays might be indicated, ECG, obviously a CT, and a pregnancy test, because we just said ectopic pregnancy. I'd like to know if you're pregnant. All right, even if it's ectopic, you're still going to secrete the same amount type of hormones. So they're going to look for that ectopic pregnancy. They can also do something laparoscopically if they need to go in there and actually look around. But and again, your biggest things are you're going to, and this is of all, but monitor INOs. You want to figure out the pattern of voiding. You want to figure out how much, when, things of that nature. So really monitoring those INOs, monitoring your vital signs. And vowel sounds are going to be important, obviously. Hyperactive, hypoactive. And monitoring for shock. So INOs and your vital signs are going to be really important when you're assessing for shock. So with shock, okay, with shock, other than your cool clammy skin, restlessness, things of that nature, with shock, the book will tell you that it's a low heart rate and a low blood pressure in several areas. You'll find it in your references. Now, hypovolemic shock is the loss of fluid, which means we don't have enough fluid in our body. Our body is going to want to circulate as much fluid as we possibly have, which would cause an increase in blood pressure and a decrease or weak and thready heart rate. But again, there are several references, and I've looked it up online. I've seen it both ways. So that's just one of your signs there. All right. So shock is going to obviously be a medical emergency, and that's one of the things that we really need to monitor for, is for shock. And we'll have to do clarification on that. But I have seen it both ways. Cool clammy skin, you're looking for that. Restlessness. Level of consciousness is going to be really important as well. All right. And let's talk about our treatments. All right. So treatments. Our immediate treatments are always going to be our ABCs. And then we're going to go in, so airway, breathing, circulation. And then we're going to go into level of consciousness and monitoring for shock. All right. Large bore, we want to push IV fluids, then we need a large bore catheter. Or if you need to replace packed red blood cells, you're going to need a large bore catheter. Also, I already mentioned complete blood work. NG tube might be indicated. Patient's going to be NPO. You might need that surgery consult, or just start preparing for surgery consult if you're not figuring out what's causing this. And again, once they figure out what's causing it, then they can give possible treatment. All right, so to sum all of that up, that's acute abdominal pain. Acute abdominal pain, you have nausea, vomiting, distension, bloating, guarding. You might find that your patients like to have one knee up or both knees up, and that has to do with when your knees are up, it releases the abdominal muscles themselves, so it relaxes those muscles. With all of your GI issues, you should be monitoring vitals, INOs, level of consciousness. Bowel sounds are going to be important. Making sure you have a large bore catheter, so if you need to push fluids or pack red blood cells, then you have the opportunity to do so. And any of your itises are going to cause acute abdominal pain, obviously. Infection doesn't feel great. Inflammation doesn't feel great. So chronic abdominal pain can, of course, result from something acute or something that would be one of your acute symptoms. So chronic abdominal pain, your causes, IBS. With this, it's not that's not that sharp, on fire, burning over pain. Say dull, aching, gnawing pain. So IBS, ulcers, hepatitis, destruction of the liver, pelvic inflammatory disorder, and then trauma, which trauma is kind of surprising, but if you have a blunt trauma, it might affect your system a little bit differently. So diagnostic studies for a chronic one are going to be your scopes, and of course you're going to have your CT scans and MRIs. Some of your abdominal trauma, so you might have a blunt abdominal trauma, which is a fall or a motor vehicle accident or something like that. You might also have a penetrating, where you're penetrating into the cavity, and that's obviously, if I have a sword through me, it is a penetrating wound. But you have a blunt, where it's just one mass force, and then of course penetrating is a more direct, sharp knife, gunshot wound. It's actually going through. So some of your symptoms associated, and again, watching for that shock, hypovolemic shock, abrasion, nausea, vomiting, rebound tenderness, abdominal compartment syndrome, abdominal compartment syndrome. So with that, it's just like compartment syndrome anywhere else except for it's in the abdominals. So what that means is that either I'm reducing the amount of space that I can push things through, or I'm increasing the amount of things that I'm trying to push through a space, which is going to result in high pressure. When I have high pressure in a space, I'm going to have tissue damage. I will most likely end up at some point having renal damage. But that high pressure trying to push through a force is caused because I've either taken my garden hose and squeezed it, or because I'm trying to put more water through it. So you could have abdominal bleeding, third spacing, edema, ascites, as some of the things that could cause that. With the abdominal, because remember your abdominal wall, with all that pressure, you could end up with respiratory failure. And again, renal failure, like I said. But the sky's the limit as far as your cause of abdominal pain. Anything that's going to increase that amount of fluid and decrease the space. So if I have edema and then I have some type of huge pop or something else restricting that movement, then I'm going to end up with abdominal compartment syndrome. And it's just where it literally cannot stretch anymore. So that's chronic. Now, the other one that we're going to talk about is going to be your inflammatory disorders, and those are your types of things. All right, so again, chronic, you have blunt or you have penetrating trauma. Endoscopic is going to be the main route here. Really monitoring for shock, and compartment syndrome is a possibility. All right, inflammatory disorders. Alright, so we have the appendicitis. Alright. Again, inflammation of the appendix is too easy, right? Usually from an infection or a buildup of infection, a buildup of feces in that area, which leads to constriction or possibly gangrene. Obviously, that's going to cause ischium and infection. It can also be caused by bacteria or perforation. And of course, if you have a ruptured appendix, it's a medical emergency. The symptoms are going to, so it might start somewhere else, but you're going to end up in your right lower quadrant, obviously. That's where the appendix is. Nausea, vomiting, anorexia. If you've ever seen somebody have this, it's really quite painful. Persistent pain, low-grade fever, and again, that has to relate back to your infection. So low-grade fever. So the tests that you're going to run for this are going to be, obviously, if I say infection, we're talking white blood cells. You want UA to rule out other causes. CT scan might be necessary. And again, if the appendix ruptures, then you can lead to infection and peritonitis. So your treatment here, obviously, is going to be removal. Not really trying to hang on to those things. Appendectomy, you can do it scopically. Keep the patient NPO. Alright, especially here though, no enemas. Or laxatives. We are not trying to push anything. All right. No enemas or laxatives. And that's appendicitis. And again, it's just trapping usually the feces in the appendix, causing infection. Although there's plenty of other causes, that bacteria and the buildup of feces is going to be a key one there. All right, so that's appendicitis. All right, so we also have, my board keeps moving, peritonitis. Obviously, peritonitis is not good. All right, so peritonitis, when we're talking about peritonitis, it's usually going to be by some type of, anything with a rupture can cause a peritonitis. So peritonitis is inflammation of the peritoneum, which is your entire cavity. All right, you have primary and you have secondary, which is kind of confusing because the secondary are more likely to occur. All right, so your primary causes, that's from your blood. It's a blood organ, or if you have cirrhosis ascites, if the fluid itself gets infected, then you can have peritonitis. Secondaries is any type of rupture. Your appendix is ruptured. Blunt trauma, diverticulitis, any type of perforation of one of your abdominal, any vital organ in your abdominal cavity, knife, gunshot wound. And these are more common. So when you have something ruptured, or when you have something that is perforated, whether it be a gallbladder or whether it be a pancreas or whatever, I mean, depending on the trauma itself, it could be a lot of things. But anything where you're spilling fluids into your peritoneal space, you're going to run the risk of infection there. And when you have that infection, that's going to be pretty severe. So your symptoms here. No. All right, so your symptoms here obviously are going to be pain, rebound tenderness, and I didn't mention it much before, but you really want to be monitoring bowel sounds for hypo, and all of a sudden the word just left me. But you're really wanting to monitor your bowel sounds for decreased activity, but basically non-working, and they'll come to me in a second. But anyhow, so pain, rebound pain, we push in and when you lift it goes away. You also have shock, and this can be septic shock. Well, it might be hypovolemic shock. It's likely to be septic shock. There we go. Paralytic ileus. All right, so my ileus is paralyzed. Monitor those bowel sounds. Acute respiratory distress, and this is likely due to fluid shifts, and it can be fatal. So this is, again, a medical emergency. When we say fatal, your immediate reaction should be ABCs. So nursing implications, we want to keep them NPO. We might have an NG tube to start draining out fluid, IV fluid, low-grade oxygen if they're in that acute respiratory distress, antiemetics, obviously they're going to be vomiting, INOs, electrolytes, and vials are going to be essential here. Again, with all of your things, monitor your INOs, monitor your electrolytes, monitor your vital signs because you're watching for shock. And again, when we say fatal, the minute we say fatal, we should be thinking ABCs because that's going to be the most important thing. And obviously, that's stopping the spread of infection. All right, so that's peritonitis. The last one here is gastroenteritis. All right, so inflammation of gastroenteritis. So this is inflammation of the mucosa or small intestines. Just abbreviated there. The symptoms are going to be sudden. Here's your trick. Sudden nausea, vomiting, diarrhea. All right. Cramping, obviously, if you're going to have sudden diarrhea, you're going to have cramping. Usually the cause is going to be bacterial and norovirus. Um, so it's usually going to be bacterial. Your treatment is going to be the same as acute diarrhea, which we'll go over here in a second. So the obviously with acute diarrhea, we're going to be pushing IV fluids. We'll want to stop the spread of infection. And if you have somebody that has acute diarrhea, are we thinking maybe C. diff, which means soap and water precautions. Even if you don't know, it's better than spreading it to yourself or another patient. Really watching those patterns of evacuation. So figuring out when they're going, how much they're going, when do we give them fluids, when are they evacuating, and patient teaching for hygiene. All right, here's hygiene. Hygiene's all over the C. diff. All right, so that's your intestines and your mucosal lining of your stomach. All right, and those are your inflammatory disorders.